Good morning. Steve Stites, Chief Medical Officer at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio. Delighted to be back with you on this beautiful, every day is a beautiful day, this beautiful Tuesday morning here in early 2021. We're back on our studio. I'm, of course, here with my good friend and our medical director of infection prevention and control, Dr. Dana Hawkinson, our Hawkeye. Also on the line today, another outstanding physician here at KU who I actually know really well, Dr. Michael Rippey. Delighted to have him to talk with us a little bit about brain fog. I'm hoping he's going to help me personally with my own brain fog during the program today. We'll get there in just a minute. First, Hawkeye, how are we doing?
Yeah, we're holding steady. We're holding steady.
That's good right now.
Yeah, not vacillating too much. Certainly not going higher, which is good. But we know that since last week we have had a lot more admissions for active infections. Right now we have 70 active infections, with 29 of those in the ICU and 14 of those needing ventilators. So we still have 56 in that recovery period. And at one point we were up to like almost 80 in that recovery period. So a total of 126 with acute in that recovery period as well. Hayes is a little bit better as well, 19 infections, 14 acute and 5 in that recovery phase. So it's really good, again, to see that hospital go down, because we know their capacity is a little bit smaller than ours here at the hospital.
It's a big deal, and it is important. And I'm a little concerned. I don't know what you're thinking about this variant that's out there and what that means for our numbers, not necessarily for severity of illness, but volume of illness.
Yeah, I mean, so the biggest issue about this variant from England, but again, they've also seen some similar variants with different number of mutations arise in South Africa and other places, is really the concern that it could possibly be more easily transmissible and spread, and that just means more people, so higher volume of infections. And even when we say 80 to 85% of the people will not need to seek medical care, when you have a higher volume of infections, a higher total number, that could lead to higher hospitalizations and, of course, later on, deaths as well.
Looks like it's going to be susceptible to the vaccine, so it just makes it even more important that you not throw away your shot when that shot comes to you, because it's really important. That's our call to arms. It's going to be there every day. We're going to keep talking about it because it is so important. Jill, let's first see if there's reporter questions.
I don't think we
don't have any.
morning.
All right. Outstanding. Well, Michael Rippey, welcome to our program. We're delighted to have you.
Hey, good morning.
Yeah.
Tell us a little bit about what a sports neurologist does.
So sports neurologist is a little bit exactly like it sounds. It's a neurologist who specializes in sports. It's mostly injuries that occur in sports, so the vast majority of that's going to be concussion. I mean, that's what I do almost all day, every day. But we see other injuries, and then sort of the other flip side of that is seeing athletes who have chronic neurologic conditions, whether it's epilepsy or migraines, and they need to be managed and have their neurologic issue optimized so that they can participate in sports at the high level they want to participate.
Yeah, it is so important, because this part about concussions and post-concussion syndrome has become more important and more relevant on our daily lives. Has it always been there, or sports concussion something that's new?
No, it's always been there. It's just something that's more top of mind now. It's certainly become much more prominent, at least as far as being recognized in the last decade or so.
Yeah, it is. And I've had a lot of personal experiences, it turns out, with one of my children having had a severe concussion. And the work of Dr. Rippey and our team there makes all the difference. Been able to go all over the country in search of some different, therapies and stuff. And I'll tell you, the best care we've had is right here with Dr. Rippey. So thank you for that. Talk to us a little bit. Well, you did a great job, man. Talk to us a little bit about brain fog post-COVID-19, and how does that relate to concussions? Because does it feel a little like a concussion? And talk to us a little bit about your work in this area.
Yeah, it feels a lot like a concussion, actually. I just saw a young athlete last week who had COVID back in the summer, and I told her, I said, if I didn't know any better, I'd think you had a concussion. Everything she described, it sounded exactly like my concussion patient. So the brain fog, they really describe it like, people always ask me to describe fog, and I say sometimes the best word is fog. They describe feeling just kind of slow. They can get to the right answer when someone asks them a question, but it feels like their processor's a little slow. It just takes them longer to get there, and everything just really seems kind of slowed down. It's not that they forget things. Sometimes they describe being more forgetful, but it's just that I think slow maybe is maybe the next best word. But fog sometimes just really is. Driving into work yesterday, I was thinking about that in the fog, and I was just like, oh, this is what people describe.
Yeah, that's got to be really hard. I mean, if you're used to being able to function at one level and all of a sudden that level changes, that really affects your life, your ability to do your job, to be in school, and all those things. How bad is this COVID-19 brain fog? When does it come on, and what? Any treatments? What happens with it?
It seems to be a little bit of a delayed symptom. Some people have it early on, but it's one that they tend to complain about sort of after the recovery of some of the other main symptoms that we typically talk about with COVID. And some patients it's lasted up to 6 months. Other people it's fairly short-lived, a few weeks. And really what I'm doing with these patients is treating them a little bit like their concussion. Early on, if it's relatively early on, we're just kind of observing and seeing what happens with it, trying to help them, with accommodations with school or work or if they need those types of things. If it gets more prolonged, we've started with more of like a speech cognitive therapy. Right now, there don't seem to be a lot of great medications for this that we can prescribe to get them through this piece or cure it for that matter.
Yeah, it's so important, and that is a concern. My wife thinks I'm in brain fog a good part of the time, actually, and especially if the Chiefs lose, I definitely have a brain fog going on that. So, do you think this could turn out to be a permanent condition for some people?
It doesn't seem to be right now. If you look back at the early 1900s flu pandemic, there's certainly some really scary literature out there about sort of permanent cognitive symptoms that have persisted after that. So far early on, that doesn't seem to be the case. Obviously we're in the grand scheme of looking at long-term issues with COVID. We're still, in the infancy probably, but even looking back at some of the epidemics earlier in the 2000s and 2010s, with similar viruses, where we've seen similar issues, for the vast majority of these patients, they don't seem to be long-term issues.
Yeah, I'm glad to hear that it's not a long-term thing. Now, I know with post-concussion syndrome, there's a lot of headache that occurs. Are you seeing the headache that goes along with the brain fog post-COVID-19?
We're seeing it a little bit. It's not as prominent. I've seen a few folks who actually that was their main complaint, was the headaches. But not, I would say probably not as much as the brain fog in the post-COVID world anyways.
Okay. All right, so now we're going to switch gears for just a minute. Let's talk about vaccination. I got mine yesterday. Hawkeye got his about 2 or 3 weeks ago? 2 weeks ago?
A week ago today.
A week ago. And Mike Rippey got his. Oh, who's that good-looking guy all dressed like that, huh? Got his KU health systems on, his vest, looking a little dorky. They said I actually sat up straight after a minute, which I normally don't do because I'm a sloucher. So let's talk about how we all feel about that.
Yeah.
Hawkeye, how are you feeling after your shot?
I'm feeling really good, actually. There was some shoulder soreness, like I said. Again, most people, certainly in that Pfizer trials, or I guess it was the Moderna trials based on the New England Journal article that was published that you referenced yesterday, average will have some symptoms for about 2.5 days. After the second dose, it can be about 3 days. That's the average. So,
what kind of symptoms are you thinking that people have?
Most of the symptoms are going to be local. So where the vaccine was injected, and that's going to be pain and discomfort. Some people will have some erythema, but other common symptoms which have occurred, which could be headache, certainly less than the site injection area. Fever, we've heard about, some people can have. Those are the main symptoms, and then just malaise and fatigue. So just kind of feeling bad and fatigue as well, and tiredness. Those really should resolve by 2 to 3 days for most people.
Yeah. Mike, how was the shot for you? How did you do with vaccination?
Yeah, I had mine last Monday, and probably same thing. My shoulder really hurt. I kind of said, I don't know if I remember an injection hurting quite that much. It was especially the Tuesday. So I got it on Monday. The Tuesday it was quite sore, but by Wednesday morning it was completely gone. So 36, maybe 48 hours total.
Yeah.
Yeah. If you want to know what really hurts, try a little IM gentamicin before you get your prostate biopsy as an old guy, and then you'll know what real shoulder pain looks like. So, listen, here was my day. Last night I got a call from Andy about throwing the ball around a little bit with Travis and Pat, and I couldn't do it because my shoulder's a little sore, and I had to defer, but I should be ready to go by tomorrow. The good news, a little nap or something, I'm ready to go back in a game. So, Andy, if you need any help with any of those things, give me a buzz. I'm ready to be there, but otherwise I feel pretty good.
Get the Chiefs ready for the playoffs. One thing I was thinking about when Dr. Rippey was talking about the brain fog. So a new article out of Clinical Infectious Diseases was basically talking about COVID encephalopathy or COVID encephalitis, which is basically infection or inflammation in the brain. And what they saw in these acute patients, what they didn't really detect the virus, but what they did detect was increase in cytokines, so that inflammatory process. And I'm not wondering, as we learn more about these long haulers, the brain fog itself, not acute things such as the encephalitis, but if it's more related to the inflammatory process and that immune dysregulation rather than actual viral infection in the brain itself.
So that just sounds bad, Michael. Immune dysregulation inside the brain. Again, I would refer to my wife's reference to me sometimes about how I act. But beyond that, what do you think about immune dysregulation of the brain?
Yeah, I think that's probably exactly what we're seeing. I think, like Dana said, it's not an actual direct infection of the nervous system. I think, some of the early symptoms that we're seeing neurologically or even stroke, and those patients appear to be much more like our vasculitis patients, which again is more of an inflammatory process. And I agree 100%. I think that's probably much more likely what we're seeing than a direct, viral impact in the nervous system, but more that downstream immune response.
You think about that, you think about some of this, the multi-system inflammatory disease in kids. You think there's any correlation to all this in adults?
Yeah, I certainly think there do. I think we still don't fully understand, we know that the virus is there. What happens with our immune system or inflammatory response to that virus? We understand that probably early on there is some decrease in the amount of inflammation in our immune response because that's what the virus does. It's able to decrease the immune response initially. But then what happens in that downstream effects, as Dr. Rippey had talked about, how is that dysregulated to cause those things that we see, both in the critically ill patients, but also in the patients that don't have to seek medical care, but still later on are having those lasting effects such as brain fog or the continued shortness of breath or things of that nature. I think it's all part of the same process. But just exactly what is that dysregulation? Why is that inflammation or that immune response different than other infections that we see, or to the extent that we see it in COVID?
So let me get this right. On one hand, I've got brain fog. Ooh, that doesn't sound good. I got long-term pulmonary complications from lung injury. Oop, that doesn't sound good. Heart injury. Oh, that doesn't sound good. Being on a ventilator. Oop, that doesn't sound good. And then even a lot of people who suffer death from this and long-term disability. And on the other hand, I've got a mask and a vaccine. Gee, I wonder which is the better way to go here. I think I got the answer. Jill, let's see what questions are out there.
Okay, well, first of all, Emily and Nadine are glad that you guys are both doing really well. Betsy wants us to know that her husband, who is a healthcare worker in Topeka, is getting his second shot today.
Second shot,
really?
Awesome. So he's going to get the whole thing. You're going to be up next week for your second shot.
No, I'm up.
Oh, you're 2 weeks. 2 weeks. That's right.
Like 2 or 2
weeks.
weeks.
Yeah, that's right.
So
we all got Moderna.
So he was obviously in one of the early
he had to be
distributions of Pfizer. Yeah,
awesome.
Good.
Yeah, Debbie, however, is concerned. She said, I have read that the Moderna vaccine is only 86% efficacy for people 65 and over. Should I wait to get the Pfizer vaccine that has the 95%?
Oh, I think that's a great question, but I believe the answer is actually in the data.
Yeah.
As we get older, our immune systems don't react quite as well to vaccination. The difference is Pfizer just recently started going back to look at their older data. Moderna actually had that as a subgroup analysis right from the start, Hawk.
Yeah, so, but I would say right now we are considering both of those really.
Well, that's a home run. But I don't think Pfizer was 95% in those who are 65 and older. I don't think they really talked about it.
Right.
Whereas I think that Moderna did talk about it, and they were 85%, which is still a home run.
And that was the overall efficacy was the 90s.
Yeah, so I would not be concerned about that statistic at all. Actually, I think you should feel very confident and very reassured that Moderna's vaccine is 85% or more effective in those who are 65 and older. That's a really good result. And again, Pfizer didn't really talk about theirs as well.
And I think if you just look at the pure numbers about severe disease in the people who had the vaccine, which was none for Moderna, and severe disease in the people who did not have the vaccine, they had 30 or so cases. So really protecting against that severe disease is
Yeah, it was a big
important as
deal.
well.
And the other thing, just to say that there was some articles that came out and published in the New England Journal, I want to say 2 weeks ago, that looked at the immunogenicity in the elderly for both Pfizer and Moderna. Moderna had a little more complete data, but they both had immunogenicity.
Yes.
So I bet they turn out to be roughly equivalent. So I would not be at all concerned about Moderna versus Pfizer. I think in the real world, I just think those two are almost identical. I wouldn't even really distinguish them too much.
They are, yeah, with the lipid nanoparticles and the modified RNAs, they're essentially the same.
Yeah, and when I say immunogenicity, what that means is how well your body responds to it and what does it reproduce in terms of antibody levels after you get the shot. The two things are pretty equal.
So Betsy was concerned about those age 65 and older in the vaccines, which you spoke to.
Yep.
Christine doesn't say the age, but she said there was a doctor on 810 Talk Radio yesterday, not ours. I don't know who it was, but it wasn't ours, who was saying that Moderna trial went better than Pfizer. A friend was listening to this and told me about it, so now I don't know what the doctor said, but now my friend doesn't want to get the Pfizer vaccine.
Yeah, again, Hawk, these are almost identical. And
Yeah.
if you look at the data, they're so close
Yeah.
because the technology is really the same.
It is.
They really do
It
the
is.
same thing.
Yep.
So thoughts about Pfizer and Moderna? from your
No, I
standpoint?
mean, nothing to add to what you've said. You know, looking at those FDA briefs, really, they are equivalent. And that is, the word from the CDC and the FDA is that as far as safety and efficacy, these are really equivalent vaccines. Now, we are continuing to gather data about reactions and efficacy, but right now, in those FDA briefs, they're really equivalent.
Yeah, so I think the good news is this. Both of these vaccines are outstanding. Do not throw away your shot.
Right.
If someone calls you and says, you're up, we're ready to start vaccinating the public, or you're an essential worker, or you're a first responder, don't say, I'm going to wait on one for the other, because they are the same. If yesterday I had been offered the Pfizer vaccine, I wouldn't have cared. I got Moderna because that's what we had in supply.
Yep.
But if someone said, you got a Pfizer shot, I'm like, okay, I don't care. Neither should you. They are both great.
Michelle has a question for Dr. Rippey. She wants to know, a person with epilepsy, are they at greater risk for neurological side effects from COVID or the vaccine?
That's a great question.
question.
And Mike, don't just focus on epilepsy. Let's broaden that out and say, what neurological conditions are there that could make you a greater risk of a problem from COVID-19 or SARS-CoV-2 and then the vaccine? So let's take it like that. We'll address epilepsy specifically, though.
Yeah, I think epilepsy in general, I wouldn't say there seems to be a higher risk of issues with the infection or the vaccine themselves. Those patients sometimes do have a little more susceptibility to just we like to say, in that case, their brain's not operating at a peak efficiency all the time. And when that happens, sometimes their low may be a little bit lower so they may be slightly more susceptible to something like the fog. But in general, we haven't seen anything specifically with epilepsy that makes them more susceptible to severe disease or long-term effects. And I would say, it really depends on the neurologic issue we're talking about. Somebody with migraines, maybe they have more headache, but in general are probably not any more susceptible to issues with the infection or the vaccine. Whereas somebody with something like multiple sclerosis, which is an immune-mediated neurologic issue, that might be something where we'd be a little bit more worried. Some of the treatments for that can present what's essentially immunocompromised patients. So those folks might want to be a little more careful about trying to avoid, well, everybody should obviously be careful about trying to avoid being infected, but maybe a little bit more so in somebody who's on a medication that may immunocompromise them. But overall, within our literature, I haven't seen anything that's really specific to this one particular disease state in neurology that makes them more or less susceptible.
Yeah, thank you. And that's what you have one, but I'm with you. I think anybody who's on immunosuppressant medication, we know a couple of things about them. A, they probably are more susceptible to bad outcomes for the viruses, and they tend to shed the virus for a little longer too, so they can be more infectious to others for a longer time, Hawk.
Yeah, I mean, I think that says it right. And hopefully you make that response to the vaccine too.
We've also seen some data about cancer patients being in the same boat, where they can maybe shed virus for a little longer if they're getting chemotherapy and have COVID-19. So we all have to be thoughtful about those things.
Melody has another question for Dr. Rippey. She suffers from migraines, and she wants to know, and she says the flu shot makes her more susceptible. She always has migraine afterwards. Will COVID make her migraines worse?
Will the COVID will the COVID
And the
do it,
vaccine.
and will the vaccine make your headaches worse? You bet.
Thank you.
This is one where I would say everybody's individualized, but yeah, probably. We see that, especially migraines. I see that a lot, that there's a lot of certain illnesses in general, or just stress to the body, whether it's lack of sleep, poor diet for a little while for whatever reason. Those things do tend to exacerbate, especially migraines.
Yeah. You know, it's interesting to think about that. But once again, folks, don't remember what Dr. Rippey just said. COVID-19 may make your migraines worse. The shot may make your migraines worse. I promise you that this COVID-19 is going to be worse than the shot, right? And the shot will be a short-term thing where the brain fog and all the things go along with COVID-19 and put you at much higher risk. So in the answer, in the real weight, if you try to weigh the two sides, you'd clearly want to go with the shot.
Oh, boy. Carolyn just got diagnosed with COVID last month. She's having a ton of problems. She said, I have shortness of breath, I have the headaches, I have glass in the lungs. She puts in air quotes. She goes, now I may be getting shingles. Is that something you're seeing post-COVID? She notes that she has numerous autoimmune conditions and is immunocompromised.
Yeah, that's tough, Hawkeye. This sounds like someone who's going to meet the definition of long haul and has some of those conditions. The good news is that most of those will resolve over time. They can be here for a long time. But what thoughts do you have for someone like that?
You know, the glass is probably ground glass opacities, which is just a way to describe findings on an X-ray or a CT.
And it represents usually inflammation and fluid and some debris in your lung. That's pretty common after lots of different kinds of lung injuries. So it's not specific to COVID-19. It's actually common in a lot of lung injury.
Yeah, I mean, I think she would be a good candidate to be in our chronic COVID or long hauler clinic, which again is really a virtual clinic, but it is set up to get you the specialties that you need, to see the people that you need to see to get it best managed. And whether that's just fatigue or feeling bad or shortness of breath, or the brain fog, anything like that, to really help navigate those types of symptoms. As far as the shingles, you know, it's really difficult to say. I don't think it's necessarily from the COVID, but we know that shingles can be brought on by stressors. This could have been just a stressor in your body, one thing to bring out shingles in this case. So
I would just advise that also to try and be patient, but with you, the shingles probably came out, and that sounds terrible advice for me to say to somebody who's suffering like that, be patient, but there is hope, and you probably will, the likelihood is you will end up getting a lot more closer to normal than you are today, but that long haul clinic might be just the place for someone like that, right?
And I would certainly recommend after the shingles, after you're recovered from that, if you haven't had it, get the Shingles vaccine, which is the shingles vaccine. And that is a 2-dose regimen as well.
So when you see these patients, and I know you're part of the long haul program as well, and some of your teammates, as you look at folks like that, what do you see as a prognosis for them? Do they, you know, Dr. Rippey talked a moment ago, the brain fog, people tend to get better. Do you think these folks are going to get better in the long haul?
You know, I think they will overall, but just as Mike had said, everything is individualized. Some may get better sooner, and some may take a little bit longer. And it also may depend on what symptoms exactly. They may not all resolve at the same time. So I think it's just a matter of trying to be patient and working through and treating those symptoms as they are there. And hopefully they will resolve within time.
We have people asking, how do you get into the long haul clinic?
Okay.
Yeah.
Do you know?
So first it's going to be starting by your primary care physician. We haven't done a go live yet. We are looking to go live soon. It's the primary care physician. And because a lot of the primary care physician is going to manage those things like fatigue and malaise, which is just feeling bad. A lot of that is symptomatic therapy. And then for the other specifics like brain fog, it'll be a referral and to neurology and getting you navigated into see a specialist who can help you with that. The same thing if you have cough or shortness of breath, it's going to be navigating to get you in to see a lung specialist to look at your lung function, maybe do imaging like x-rays or a CT if needed, and really help managing those symptoms, because it's symptomatic management at that time. It's not really antiviral management. We're not managing COVID itself or the virus itself. It's all these effects afterward.
So remind me, do we have Dr. Brandon Comfort coming on the program soon?
Who?
Dr. Comfort, was he coming on our program
yes,
soon?
I think
It's
Monday.
It's next week. So I just say to our folks out there, we'll talk specifically. We have about a week devoted to long haul symptoms, and
yes.
and the Dr. Comfort will lead it off. He's our pilot. He's really the person who's helping us head that up. So stay with us on Monday, and we'll be able to talk to that and address it very specifically about a lot of those questions.
To that point, we have people asking a lot about taste and smell. We do have a specialist on that is also going to be one of our guests.
Yep.
However, one of the things that they are saying is that when they do get their smell back, things that were nice and like coffee and they liked it, now smells like garbage. They want to know, is that?
Well, let's talk to Dr. Ippy. I think that's a neurological question. What do you think? Can we dump that one on you, man?
You can dump it on me. I'm not sure I'm the right guy to ask. I haven't seen that specifically with COVID. I'll draw a little bit on my TBI background. It's a really small.
So TBI, everybody. Hey, Mike, just a second. TBI is traumatic brain injury for those, and it's basically concussion. So I wanted to make sure everybody knew that.
Yep, right. I probably got 10 patients. Again, I can count them on two hands who've had loss of smell, and it does tend to come back. I haven't heard. It tends to be a long process, though. But I haven't heard anyone in that group who's recovered their sense of taste or smell and complain that it's different afterwards. So I guess the short answer is I don't know.
Okay, so I'm seeing this. There was some art. I read about this. Gosh, was it yesterday? Talking about will people have the right nutrition when they've had us change a sense of taste and smell? Because I don't think we know yet, Hawkeye, what the full course of that's going to be.
Yeah, I don't think we do either. I think what we do know, the little bit about what we do know about that specific symptom, is that I don't believe, and certainly Mike, stop me and correct me, I don't believe we're really getting infection of the nerves, of the olfactory nerves that are actually making the sense of smell, but it's really an infection and destruction or damage to those surrounding supporting cells around there. And so as you have those supporting cells recovering and maybe getting scar tissue or getting rid of the scar tissue or the inflammation, that is when slowly you will have your sense of smell and taste come back online. It's not necessarily an infection of those nerves that making the sense of smell, but all those supporting cells around that area.
Yeah, and let's remember too that many people who have the common cold lose their sense of taste and smell, right? If you have a cold, things taste different to you. For example, I can eat really hot, spicy foods when I have a cold. I can go nowhere near those when I don't have a cold. And it's just different because our sense of taste and smell are affected by inflammation and infection. What happens over time is that almost always those things begin to return to normal. It can take weeks. I think there's also this thing, well, I'm better. I should be I should be fully recovered. But the reality is it can often take months to fully recover. If you take a bad dose of influenza, I had influenza last January. I got pretty sick. I turned 60 on January. Well, I'm not going to tell you what day I turned 60, but I turned 60 last January, a year ago. And what I was sick, and we had this big party. I'm going to party for 60. I was locked in my bedroom for the entire party because I had influenza. It took me 3 months to really feel better. Don't be surprised if it takes you months because coronavirus is a virus. Post-viral illnesses can take months to recover from. Don't be surprised. Sometimes something like a viral illness like Guillain-Barré, which is a response to a viral illness, that response can take 6 to 12 months to get better. So don't be surprised if this takes a long time, and don't say, well, this is only something that happens with COVID. Well, no, actually it happens with a lot of different things, and it can take a while to get better from. So don't be surprised if your sense of taste and smell changes with this. It's more pronounced. That's true with this particular thing, so that's a little unusual about it. And sometimes when you have coronavirus, the sense of taste or smell may be your main symptoms, which isn't really true of the common cold. But you can have, like a common cold, the changes of taste and smell, and those will take a while to get better. And don't be surprised surprised if it takes months. And yes, things may taste differently to you for a while. I suspect, this is now I'm speculating, I suspect that over a period of 3 to 6 months, your sense of taste and smell will end up getting closer to baseline. But we won't know that till we have a lot more experience with COVID-19.
Yep, absolutely.
Cheryl has a question for Dr. Rippey. My 90-year-old mother with dementia had COVID, and now she has brain fog. Will the brain fog affect the dementia permanently?
Oh boy, Michael, that's a hard one. I'm glad you're here.
Yeah, I think I'm going to take something you just said and say I don't know that we have the data on that. My suspicion is that, again, they're two very sort of different processes. So I'm suspecting that overall it will not. But again, we see, especially with dementia patients, even minor illnesses can really affect their cognitive abilities at that point. So that's really hard to say, and I think we just don't have the data on that long term to know how that's going to affect it overall.
Okay, Michelle wants to know, this is also for Dr. Rippey. My mom had a stroke over the weekend. They are attributing it to AFib, new diagnosis, but they did not test for COVID. Should I request a COVID test since it's known to cause coagulation issues?
Interesting, good question. Although most people should be getting tested for COVID in a situation like that.
I mean, I don't think it's a bad idea to ask. I will say the more likely cause in that situation is far and away the AFib. Even if we want to speculate and say it was actually a COVID issue, the AFib is going to really increase risk of recurrent stroke and is going to need to be treated. And frankly, the treatment may end up being the same. But so I don't think the COVID diagnosis would change my treatment plan in that particular situation. I think the AFib is, again, far more likely to be the culprit there.
Yeah, but we do want to check for AFib, or AFib. We want to check for that too.
Yeah.
But for COVID, because that has a lot of implications to the people around her and who's going to help get her care and things like that. So it's certainly important to check. Okay, 1 or 2 more questions.
Sure.
I have to go to clinic today, everybody, just so you know.
Okay, Anil has a question for you.
Anil,
Yeah.
how are you? We hope you're doing better, man.
I think he's going to come on our long hauler clinic too
Awesome.
when we
That's the
have our
perfect time.
pulmonary doc on Wednesday next week.
Okay.
Anil wants to know if you still have post-COVID inflammation, should you wait until the inflammation is gone to get the vaccine?
Ooh, that's Anil. You should be sitting up here as part of the expert panel because you asked such good questions. Hawkeye.
I would say no. So right now, based on some of the CDC guidance and their slide sets, especially when Pfizer first came out, what they do say is there is no minimum time between infection and getting the vaccine. So that's the first point of guidance. What we do say is that, well, if you have active COVID, you probably do want to wait a little bit to, number one, make sure you don't go into a vaccination clinic while you're acutely ill to possibly spread it to other people. But also, if you actively have it, again, waiting for you to recover. Now, if you have already recovered, what we have been saying is that maybe you want to wait 60 or 90 days only for the fact that you now have some immunity. And if we can use a vaccine dose to get somebody vaccinated who doesn't have immunity, we would like to do that. But again, there's no minimum time between infection and vaccination. So certainly, especially if you're a long hauler and have symptoms, we know that reinfections occur. They can occur 60 days or less, 90 days or less. We don't know exactly all on who and how many, but we know that they can occur. So it would behoove you to get the vaccine. Specifically talking in Anil's case, he is far enough out. I would certainly recommend getting the vaccine as soon as he's able.
Yep.
Okay, and Anil, we hope you're feeling good on Wednesday, and we'll talk to you more then.
Yep.
Joanne, last question. My 32-year-old nephew had a TBI, traumatic brain injuries, we learned, 8 years ago. He is still recovering. So far, he has not gotten COVID. If he gets COVID, could he relapse?
What do you think, Michael? So many things can cause relapse and TBIs. Would COVID be part of that list?
Yeah, I mean, I say that hesitantly because, I think you hit it. A lot of things can cause that. I think if he's had, again, thinking very specifically about this person in the question, if he's had influenza or something like that and did well with it, the likelihood that COVID causes a significant relapse with his TBI symptoms is probably lower. But again, I wouldn't cross it off the list and just say, oh, absolutely not. As we know, again, with a lot of these, I mentioned with dementia already and some of these other neurologic conditions, sometimes it doesn't take much of a stress to the body to really to flare those symptoms up. So, it certainly could, increase some of his TBI-related symptoms.
Yeah, sounds true. I appreciate that. And Michael, let me just say how much we appreciate your being here. Again, Mike Rippey, one of our outstanding neurologists, a sports neurologist. And as I've said, I've been to Mayo and to Hopkins and all sorts of really cool places. But Dr. Rippey has done the best, and we so appreciate the great work he does here in our health system. Hey, tomorrow, well, I'll be back to you in a second. Tomorrow, Dr. Marissa Love joins us. She is an allergist here at KU. She does a great job here at the health system. And she's going to talk to us about the questions around COVID-19, about vaccination, and about allergies and how to stay safe. She's also going to tell us what she's recommending to patients and their biggest fear about living with allergies and or taking immunosuppressant medications, and especially those who have to take those medications and be at risk for COVID-19 and what that means, et cetera. So a lot of stuff, and it'll be a great program. We hope you're back with us tomorrow. Dr. Rippey, final thoughts.
I think my final thought is, if you get, like you said, if you get the chance, get the vaccine. I think that's probably your best bet. There's all these hypothetical questions. What if this happens? Hopefully you get the vaccine, and then don't forget, just because you get the vaccine, all those social distancing and mask wearing, all the other rules still apply at this point. And yeah, I think that's my final thought.
Thank you. Hawkeye, final thoughts today?
Yeah, I think piggybacking on his thought, there's a good article in New England Journal of Medicine under the COVID-19 topics. Again, that is free to the public. They review actually the allergic reactions to the Pfizer vaccine. So it's a good review. If you're really having hesitancy, that's one other source you can go for truth. Go take a look at that and read through that a little bit. Hopefully it'll make you feel better. But get the vaccines. We are, have got a lot of employees vaccinated now here at the health system, and we are hopefully going to be ready, and I hope everywhere around the region is going to be ready as soon as it's able to be rolled out to the general public, that everybody goes and schedules their time and gets their vaccines.
Yeah, so important for all of us to remember those things. We've talked to you a lot about how we were building the airplane while we flew it. If you remember back when we first started with this program, we often said, give us 2 weeks, we'll be a little smarter. Give us 2 weeks, we'll be a little smarter. And here we are getting close to our 200th episode. We're a little smarter. Doesn't mean we have all the answers at all, but we'll always be honest with you. When we started this journey, we talked a lot about hope and faith to try and get us through this crisis, while science helped get us the answers that we need and the treatments. Science is now delivering. This vaccine is one of the most remarkable achievements in healthcare in the history of human civilization. And I'm not trying to be dramatic about it. That's just true. If you look at how fast it's come about and its safety and its efficacy. But it only will work if it's in you. So now it's your turn. Faith, hope, and science brings us to a point where we can bring life back to normal and end this thing. But it's going to take you. And without you, we're going to still be fighting this battle a little longer. We hope you're with us. Join the call to arms when you get your call to have this shot. It is a life-changing event. I want to get back to normal. So do you. Let's get it done. We're here tomorrow.